This is an educational video on endovascular management strategy for cerebral venous sinus thrombosis being presented by Omar Choudhri, the fellow in endovascular neurosurgery at Stanford, with Abdullah, Feroze, Michael Marks, and Guido as the other authors for this video. The main goal for this video is to discuss the different management options available in patients that fail medical therapy in the setting of widespread cerebral venous sinus thrombosis, and to discuss potential options available to a neurointerventionalist in this setting, and additionally to discuss some of the techniques that we used in this particular case. This case is of a 63-year-old male who was transferred from an outside hospital with symptoms of feeling tired for 1 week, had associated headache, nausea, vomiting, and photophobia for 2 days before presenting to the hospital. In terms of past history, the patient had a history of gout and BPH, had a sister with a history of abdominal thrombus and mesenteric thrombosis possibly. The patient was a non-smoker and was a cardiac surgeon by profession. On clinical examination, the patient had a normal examination, apart from being slightly drowsy, but was fairly oriented. Had a high creatinine at 1.4, indicating dehydration on presentation. This is the non-contrast CT that the patient presented with, and you can appreciate a small amount of sulcal hyperattenuation consistent with a small amount of subarachnoid hemorrhage. This is the run through the same CT scan where you can see the blood layering around the tent a little bit and some blood along the sulci on the left parietal lobe. An MRI that was done at the outside hospital demonstrated no significant infarcts in the diffusion. However, again, on the gradient echo and MR sequences, there was demonstration of blood. On the MRV reconstruction, there was evidence of an occluded superior sagittal sinus, transverse, and sigmoid sinuses. This is a Bravo sequence, thin cuts, and a scrolling through that, and you can demonstrate there's a complete occlusion of the superior sagittal sinus with a clot sitting across the whole length of it, and bilateral transverse sigmoid sinuses, indicating widespread venous sinus thrombosis in this patient. This is a sagittal image of a Bravo sequence demonstrating an entire length of clot in the superior sagittal sinus as depicted by the arrows in this picture. This patient had a significant clot burden and was very symptomatic from it, given his clinical features of worsening headaches, along with drowsiness, and after a clear history of being dehydrated. Based on these images and the clinical presentation, the patient was given a diagnosis of widespread cerebral venous sinus thrombosis. The patient, however, clinically deteriorated later in the evening, became less responsive, and therefore the neurointerventional service was paged, and decision was made to take the patient to the cath angio suite after anesthesia, intubation, and placement of a radial arc line and a central line. We used a biplane angiography suite with general anesthesia. The patient was supine with the head strap. This is a picture during the case which demonstrates the biplane suite where we complete these procedures in a standard fashion and employ general anesthesia with close monitoring of vitals for these procedures. The axis is fairly standard. We used a femoral arterial axis and both a femoral and an internal jugular venous axis. So you can see that we had a left femoral arterial line, a 545 sheath for completing a cerebral angiogram before the start of the procedure, and a right femoral venous line, which was an 845 sheath, and we used a left internal jugular axis later on in the case to allow better access into the left-sided transverse sigmoid system, which was done using an ultrasound, and a 6 French 11 centimeter sheath was used. We completed a diagnostic cerebral angiogram that demonstrated an occlusion of the posterior superior sagittal sinus, and this is the run through that angiogram, and you can see in the right injection in the venous phase you do not see any filling of the superior sagittal sinus or the right transverse sigmoid system. On the left side, injection demonstrates the same thing. There's venous hypertension, there's stasis, there's no filling of the superior sagittal sinus or the transverse sigmoid system, given the widespread venous sinus thrombosis present. An injection from the vertebral artery demonstrated the same thing, with venous hypertension and no filling of the transverse sigmoid sinuses and severe venous hypertension and engorgement of the cortical veins as seen on this angiographic run. Again, a lateral angiographic run to the left vertebral artery demonstrated the same thing. Important to see that even though the straight sinus was patent, no egress was possible because of a clot present at the torcula and across bilateral transverse sigmoid systems. An important thing to be raised is the a combination of techniques was used, namely suction thrombectomy using the penumbra aspiration catheter, solitary stent retriever, which was used in the suprasagittal sinus. We used some TPA through the microcatheter. We used a postus angiojet, which is a rheolytic thrombectomy system, and also a balloon embolectomy. So the suction aspiration thrombectomy was primarily done using a 5 max ACE catheter, which was placed in the suprasagittal sinus. And on these views, you can see that the ACE catheter is in the suprasagittal sinus, and we've actually passed a solitary device through it. So a few more images demonstrating the solitary device in action. This is the venous run completed with the suprasagittal sinus, where you can see a lot of clot burden with stasis in the posterior portion of the suprasagittal sinus, and you can see those engorged cortical veins on this injection. In these views, you can see that the solitary device retained by the velocity catheter, a microcatheter, is slowly being unsheathed in the suprasagittal sinus. Once it's completely open, it's left in place for a couple of minutes before it is pulled back to allow clearance of the clot. And suction at the time is applied through the ACE aspiration catheter, and you can see that the solitary device is being pulled into the catheter on these lateral unsubtracted views. This is the angiographic run afterwards that demonstrates improvement of flow in the suprasagittal sinus. Another technique used is the IA therapy, which I mentioned we give through the microcatheter
IV TPA therapy
of the sagittal sinus and the transverse sigmoid sinus. Balloon embolectomy is in the process in which we use a large 6 to 8 millimeter balloon, a peripheral balloon, which is basically inflated and pulled back across the sinus with the thought that it's going to pull the clot with it. It's something as a procedure that's used by the body IR people in the peripheral vessels, and again, this is a last resort thing in patients who have a lot of clot burden, and this way the clot can be pulled into the catheter, but there's a risk of causing pulmonary emboli, which are small, but again can be useful.
Another therapy is the angiojet rheolytic mechanical thrombectomy, which employs a device that essentially employs suction. So the thrombus is drawn into the catheter, where it's fragmented by these small jets that come out of these side ports that you can appreciate on this diagram. And ultimately, the thrombus that's broken down is suctioned in and is evacuated in the body. It's a fairly extensive setup. It comes up with catheters that are 4 French, 5 French, or 6 French. The 4 French and 5 French catheters can work through a 14 thousandths wire. However, the 6 French catheter requires an 0.035 inch wire for selection. So it's very important to know these features before you can decide what catheter is going to be compatible for the passage of these devices. This is an intraprocedural view demonstrating this angiojet device setup, and another X-ray showing the angiojet device, the 4 French and 6 French in the suprasagittal sinus. This is us in progress during this case, using the angiojet across the sinus for aspiration. And finally, the angiographic run after treatment demonstrates a much improved cerebral transit time, improved venous drainage with patency of the sagittal transverse sigmoid sinuses bilaterally. The patient had the heparin infusion continued post-operatively. The sinuses remained patent. The patient was able to follow commands and was discharged to rehab, and finally transitioned to Lovenox. So this kind of summarizes the different therapies available for endovascular mechanical thrombectomy for venous sinuses and setting of venous sinus thrombosis. This brings me to the end of the video. Thank you very much.